Here's the truth. A good latch can make or break your breastfeeding journey. It's the difference between painful, stressful feeds and a smooth, nourishing rhythm that works for both you and your baby. Welcome back to this week's episode of the Milk Production. Behind the scenes, I've been deep in editing mode for the first prenatal breastfeeding preparation course for the Academy, which I hope you've been hearing me talk about for a few weeks now. Honestly, the hardest part so far has been just finding a quiet place in this tiny house with 7 people. At one point, I kicked my whole family out, spent the entire day filming, and then the lighting was so bad I couldn't use any of it, which was maddening. On a lighter note, iced green tea is my latest little discovery that's getting me through. I don't know why it never dawned on me before. I love black iced tea, but I've been drinking hot green tea lately for the health benefits. And then last week it hit me. I could just make iced green tea. Silly and simple, but it's kind of been life-changing. And during the recent late nights editing, I have really been able to use it. So enough chitter chatter. Let's get to the point. Today, we are talking about Latch, what it is, why it matters, and how to troubleshoot when it's not working the way that you hoped. If you want the highlights or the show notes, you can always find them at themilkproduction.com. And don't forget, I post the clips from episodes like this on Instagram, Facebook, and YouTube, all at The Milk Production. So if you don't have time for the full episode, you can still catch the essentials. So what exactly is a latch and why do we care so much about it? Latch is simply how your baby attaches to the breast. But it's not just about being on the nipple. A deep, effective latch means your baby's mouth covers more areola, the tongue cups the breast, and milk transfer can actually happen. A shallow latch often leads to pain, nipple damage, and less milk intake. So now that we have kind of a good understanding of what a latch is, which you will hear all the time when you're talking about breastfeeding and lactation, let's talk about what the difference is between a shallow latch and a deep latch. So a shallow latch is when baby is attached to the breast, but the nipple is not deep enough into the mouth to make it comfortable or to effectively transfer milk. And that shallow latch has some tells, namely pain. So a lot of moms can tell that the baby's not latched deeply. I should say the majority of moms can tell that baby's not latched deeply simply by the first indicator, which is pain. Now, that's not the case for everyone, but in general, if you feel latch pain, likely the latch is not deep enough. There are other tells for a shallow latch, one of which is you may hear clicking in baby's mouth while they're attached to the breast. Shallow latches can happen from the positioning of baby, or it can be that there are other issues going on. For example, mom has short nipples, and so the nipple is not able to get deep enough into baby's mouth, or baby has a really high palate, or something with the tongue is, for example, tongue tie or some other kind of tethered oral tissue is preventing the range of motion of the tongue to hold the nipple in the roof of the mouth and maintain that deep latch effectively. So kind of talking through that, the role of the tongue and sort of the oral mechanics of what's going on is when baby latches, sort of opening the mouth wide, the nipple goes into the roof of the mouth at an angle. So if we think of this as the hard and soft palate, we want the nipple to reach the point where the hard and soft palate meet and maintain that position. And the tongue and the muscles in the mouth are helping the nipple, once it reaches that spot, to stay there, and it should be comfortable. It should be not painful for mom. Now, a little bit of initial pain at the beginning of the latch, that resolves, I would say, within maybe 10 to 30 seconds, can be normal in the beginning as you're getting used to that sensation of nursing and the tugging and just using your nipples in that way, and the moisture and the friction and that kind of thing. That can be normal, but if pain persists into the feed, that can be an indication that there's a shallow latch happening. And so instead of the nipple being up into the roof of the mouth, again, where the hard palate meets the soft palate, it is maybe slipped out in some way. And so the baby's kind of trying to use other muscles or use the tongue differently or kind of compress that wide open mouth that's supposed to be sort of a wide gape when baby latches. Then they start to kind of compress that to try to hold the nipple in the place that it needs to be. And the tongue might slip back, and they might use the gum to also kind of hold that. And that can create pain and also decrease milk transfer. In the early days, newborns are so particular about positioning and latch. And because of that, we need to be really diligent about setting them up for success. And in doing so, I find a lot of times that decreasing a mom's pain at the breast while feeding is not actually a big enough motivator for most moms. Most moms are like, baby's on, this is good for them, they're doing it. I'm not going to, adjust anything because baby's latched and staying on. But if you're in pain, it's actually a really good indication that the latch is shallower than it needs to be, and that we could increase how much milk baby is transferring by deepening the latch. So that's what I want to stress here. I'll probably hit that several times, keep coming back to it today, but this talking about the latch and level setting about what it needs to look like is not just so mom feels better. It's so baby gets more milk transferred in a single feed, which can resolve a host of issues. If you're seeing slow weight gain, or if baby's eating frequently, more frequently than we would expect, those things can likely improve by improving the latch. Why does latch matter so much for breastfeeding success? Latch impacts everything: comfort, milk transfer, and supply. A poor latch can mean pain, cracked nipples, and inadequate milk intake for the baby. A good latch protects your nipples, helps your baby feed effectively, and supports your long-term supply. Here's an important point to frame this discussion. The biggest reason why moms don't go on to meet their individual breastfeeding goals is because of unresolved nipple pain. So I've been there. Literally toe curling pain. Every time you go to think about latching baby, your body gets tense, you get stressed, et cetera, et cetera. It doesn't even have to be that bad. Even if you have pain and you're like, okay, well, it takes 5-6 minutes to resolve, but then I don't even know if it's resolving or if I'm just becoming desensitized. These types of concerns, and especially when you see that damage happening on the nipple compression, cracks, bleeding, any sort of nipple trauma, those types of concerns can be resolved by deepening the latch. And again, as moms, a lot of times we want to push through the pain and say it's best for baby, we're going to get through this. But understanding that it's a true barrier to breastfeeding success is important. So it's really important to listen to your pain, and let's do what we can to try to prevent that trauma from occurring. And then if it is, resolve it by adjusting the latch and caring for those nipples. As previously mentioned, milk transfer is really important here too. So efficient feeding supports baby's weight gain. Again, newborns are very particular in the early days, and they like their feedings just so. But we are very particular about newborns too. We want to see weight gain at a certain rate and amount per day, and making sure that we have those effective, efficient feeds with deep, comfortable latches maximizes milk transfer, which in turn supports weight gain. So again, really important in terms of milk transfer as well. A deep, effective latch protects long-term supply. So the stimulation and removal of milk in those early days is determining your long-term supply. So if we are not removing enough milk or decreasing the frequency that we're bringing baby to the breast because of how painful it is, then we could negatively be impacting supply, which would drive down production and could even impact it in the long term. When a latch is more shallow or not deep enough, you can also see an increased rate of potential problems like clogged ducts, mastitis, or low supply, like we previously discussed. You might see those because not enough milk is being removed to clear out the breast. Ducts are clogged because of the subsequent engorgement. Some theories posit that mastitis can be a result of an initial clogged duct that worsens. So we want to prevent those issues from occurring by maximizing milk transfer and comfortability at the breast by making sure that baby has a good deep latch. How do you know if your baby actually has a good latch? A good latch feels comfortable after the first few sucks, not painful. You'll see baby's lips flanged, more areola showing above the lip than below the lip, the chin pressed into the breast, and the jaw moving to the ear. You should hear or see that suck, swallow, breathe pattern, and hear audible swallows. For more information on how to know your baby's getting enough, we did talk about this in episode 15 from last week. I get this question all the time. Is it normal to have pain while breastfeeding? And yes, it's common, but I wouldn't necessarily say that it's normal. Breastfeeding should be comfortable with, if you do have tenderness or something like that, discomfort that is resolving. We want to make sure that we're not incurring damage at each feed and be protective, defensive even of those nipples. Nipple defense is real. We want to do that because we want to protect and preserve long-term breastfeeding success. So how do we make sure that's happening? We first want to talk about positioning. Baby's positioning is really important to make sure that we're setting them up for success. Couple things come to mind that I always like to cue as parents are breastfeeding. No matter what position, these hold true. So one term called hugging the breast is where we tell mom to have baby's hands on either side of the breast. So breast in the middle, one hand on either side. So in cross cradle hold or cradle hold, you would have one of baby's hands underneath your breast and the other on top of the breast. In football hold, same thing. In laid back breastfeeding, one hand on either side. And what that doesn't look like is if you're doing cross cradle hold, one hand coming across the baby's stomach and then the hand on top being on top of the breast. This hand or both, I love the little prayer hands that babies a lot of times do. But if those hands are here and baby's trying to latch and get close to mom, they become an impediment to a good deep latch. So you want to take those hands away and move them to the side so that baby can get closer to the breast. You want to start with baby's nose lined up with mom's nipple. So sometimes what that looks like is baby's a little more to the left or right than you would initially think. What that allows is for baby's head to be slightly tilted back, and this allows the chin to lead as baby is going toward the breast. So turning to the side to show you that. Slight tilt back allows the chin to lead as you're bringing baby to the breast. Then that chin presses into the breast. Now, before baby latches, let's make sure we talk about the gape. Babies should exhibit a wide open gape, and I've referenced this in other episodes, but textbooks call it 120 degrees or something like that. We want baby to be opening as wide as possible. Sometimes babies will give you a little bit of open, and you try to take what you can get and push your breast in there in the small gape that they give you. But really you want to take that moment to teach them to open up wider. And you trigger that reflex of them widening their gape by, if you're holding your breast in your hand, hold your breast such that your nipple is touching that upper lip or starting at the nose and going down like this. This triggers baby's mouth to open wide. If at first they give you a little open, keep doing that a couple times, and a lot of times you'll see it start to get bigger. And when you see that mouth open really wide, that gives you the opportunity to compress your breast and try to push as much breast tissue into baby's mouth as possible to get that nipple up to the roof of the mouth where we want it. In doing so, what that looks like is your nipple is aimed up to the roof of the mouth behind baby's nose. I like to tell families to use that as a marker because it's exaggerated. That's probably a little higher than baby's palate, but it gives us a good marker to say, oh, the nipple needs to go at this angle. So if we say this is baby's mouth, it might be sort of natural to think, oh, we just go right in the middle of the lips, right? But really what we want to do is go up at an angle to the roof of the mouth. That's why you'll sometimes hear latches be talked about as asymmetric. And that's why we also talk about a lot of times you see babies have more areola from the bottom side of the breast that they're on than they do on the top. So if this again is the nipple, then they're going to get more areola underneath the nipple than if they've got that nipple pointed to the roof of the mouth, than they will on the top. Okay, and that's an asymmetric latch, and that's good. That's exactly what we want. Use the nose as your marker to aim that nipple up to the roof of the mouth. When you're compressing your breast with your hand, what that might look like, again, regardless of what position you're in, the thumb ends up across from baby's nose. And what that allows you to do is as you slightly depress on the breast, you can see your nipple aim in a certain direction. So we call this like a C-shape hold and a U-shape hold. So if you're doing, for example, cross cradle and baby's feeding on your breast, a lot of times what we see is moms C-shape hold their breast, but really they need to move it into a U-shape hold. And so then that puts the thumb across from baby's nose and allows you to aim the nipple up to the roof of baby's mouth. Okay? So again, once baby's wide open gape, leading with the chin, upper lip coming up and over the top of the nipple and latching well, you should see good jaw motion to the ear, cheeks rounded, no dimpling, even though it's really cute when they do have dimples. And you want to start to listen for the other things like audible swallows, hear how they're doing with that suck, swallow, breathe rhythm. And just monitor how baby's doing. If baby's popping off frequently, or if, oh, this is another thing that's so cute that they do, that's typically an indication that the nipple's not getting where it needs to be. They will get on the breast, or even the nipple will be right there inside their lips, and they bob around, and they sort of bob around, and maybe in frustration, they pull away or get worked up or just kind of bobbing and trying to go for it, and they're not latching onto the nipple because the reason why we want that nipple to get to the roof of the mouth is twofold. First, it creates the opportunity for that deep asymmetric latch that's more comfortable, that maximizes transfer, all that good stuff. But also, baby has a suck reflex that's triggered when you touch the roof of the mouth. So for example, if you have baby suck on your clean finger or gloved finger, something like that, soft part of the finger up to the roof of the mouth, when you touch that palate, it triggers baby to start sucking. And it's the same thing. You achieve the same effect with your nipple. If you can get your nipple to that part of the palate, babies feel that, their suck reflex is triggered and they start sucking. So just knowing those things to look for, or knowing the signs that are exhibited when baby's struggling a little bit to get that good rhythm started, is helpful. Again, audible swallows. And then after baby feeds, you want to see a satisfied baby. So maybe they start at the beginning of the feed with their hangry hands, really tight fists. You try to pull it away, it pops right back. Then as they feed, the hands are starting to relax. Maybe still a little tight here. And then as they start to fill up, the arms come down. And then by the end of the feed, it's just like spaghetti noodles. That is a good sign that baby got enough as well. If you do have any deeper questions about how to know your baby is getting enough, you want to talk about sort of the indications that they're not, or red flags, or how to know when to get help, all that good stuff. Last week's episode 15, how to know your baby's getting enough, covers a lot of that in good detail. So what are the red flags that tell you a latch isn't quite right? Painful feeds, nipple compression, or visible damage are all signs of a shallow latch. If your baby keeps slipping off, making clicking sounds, or if you see cracked or bleeding nipples, that's a clear sign something isn't right with the latch, and it needs attention before it impacts milk transfer and comfort. So talking about that painful latch, beyond the initial first few seconds of the latch, how do we know if it's the kind of pain that's not okay? I don't love using the pain scale, especially after watching that documentary on the Sackler family, because they created it. But it is helpful. It gives us a sort of basis to talk about, and everybody's pain threshold is different, but it gives us a basis to talk about what type of pain we're discussing here. And we're talking to, people who just went through with labor, something quite painful. So it's not as if most people just exaggerate the pain. So it does give us a pretty good reference point. And what I typically say is 2 to 3 on the pain scale is what I would consider fairly normal, especially if it's resolving after the 10 to 30 seconds into the latch. If it persists, then there's probably something we can optimize. And certainly if you're talking about a 6, 7, 8 on the pain scale, that is much higher than we want. So a lot of times, I'll have conversations with mom and I'll say, on a scale of 1 to 10, how painful is this right now? Baby's just latched. And they will say, it's not bad. It's a 6 or a 7. That is bad. I want you to be thinking between a 3 and a 4, we're going to be doing something different. And if you're even wondering if it's a 4 or if it's in that 2 to 3 range, we're going to do something different. Because the hope is, if it's a painful latch, that's a very clear indication. We've caught our problem. We need to deepen the latch. And we can do several things to deepen the latch. So pain is a very clear indicator, and it's definitely something that you should listen to. Another indication would be clicking sounds and baby slipping off the breast. So clicking sounds, even while baby stays latched, is another good indication that the nipple is not quite staying in that spot that we need it to between the hard and the soft palate, where the hard and the soft palate meet. If that's happening, that can lead to inadequate milk transfer and nipple damage and compression of the nipple as well. So listen for those clicking sounds. A lot of times the easiest fix for the clicking sound is, if you've got baby latched in cross cradle hold, compress your breast with your hand, not your body. Press it a little bit more forward, and then bring baby in a little bit closer. So in cross cradle hold, you end up supporting baby's head here. This part of your hand often ends up between the shoulder blades. Use this part of your hand to sort of bring baby in closer. And what that's doing is, still baby's head is slightly tilted back, just moving them in closer to the breast. So you bring them in closer at the shoulder blade, that brings them in closer to the breast and deepens the latch. If the clicking sound goes away, it worked. If it's not going away with that small adjustment, break the latch and try again. So another indication that something's going on, nipple compression or creasing after feeds. You'll hear this referenced in all type of ways. One of the easiest visuals is you got a new tube of lipstick and it looks, perfectly unused and it has that crease on the top. Nipples can look like that from a poor latch. So if you're seeing your nipple go into baby's mouth round, coming out looking like a new tube of lipstick, that is an indication that the latch is not deep enough. If the nipple is reaching the roof of the mouth where it needs to be, it should maintain the same shape that it was when it went in. Now, it might be bigger because of that suction and the elasticity of the nipple during the feed, but it should not be compressed or creased. If also on your nipple, you see a line of damage, whether that's white or scabbed or something like that, that's an indication that compression of your nipple is happening in the mouth and that you're incurring some damage from that. In that case, I would be very diligent going forward at each and every feeding session until you and baby are mastering this latch to always, again, check in with the pain, even if you're not having any, if you are getting that creasing, doing everything you can to sort of look at baby's positioning, lips flanged, closeness to the breast, everything that you can to make sure that you're setting baby up for success in that position and that you're positioning yourself to maximize that deep latch. So talking about that scabbing, cracking, blistering, bleeding, all of that is an indication that something's going on with the latch. It's not normal to get that level of nipple trauma while breastfeeding. A lot of times you can get online and you can see everybody's stories, some horror stories and some just like, oh, this is pretty normal. And it is important to talk about the fact that cracking, blistering, bleeding, scabbing, nipple damage can all happen, but it's not a rite of passage. It's not something that you need to suffer through. It's not, your nipples toughening up, that kind of thing. It's an indication that the latch is not deep enough and that we want to adjust it. Unfortunately, the normal milk making process includes a period there where you might get engorgement. So think somewhere between 3 to 7 days postpartum as your milk is coming in. You can have a day or two where your breasts are very full and hard. They can be as hard as your forehead. That can be, aside from the fact that it can be very uncomfortable for you, it can make the latch harder. So that engorgement that happens is not necessarily just from the increase in milk production, because as you move forward, you might be making more milk, but you won't have that same engorgement sensation. Some of it may be inflammation, and some of it can be if you had fluids during delivery. A lot of times you'll be warned that the fluid can pool in your hands and your ankles and your feet, and you might even see that before you leave the hospital. The same thing can happen in your breasts. So lymph fluid, increased blood flow, and increased milk are all contributing to that engorgement sensation. And as such, so if your breast, if your nipple's here and your breast is really full, fuller than usual, then that nipple may not be as easy to latch onto for baby. The tissue behind the nipple at the areola can feel less elastic, less compressible, and make it difficult for baby to get a full mouthful of. If that is the case, one of the techniques that you can try is something called reverse pressure softening. So if you have your areola with your nipple in the middle, that is where we want to try to get some of the lymph fluid, blood, milk, all that good stuff away from the nipple. And in doing this technique, we also stimulate around the nipple, which then can make the nipple more erect and easier for baby to latch onto. So reverse pressure softening helps us by both getting some of that fluid away for the short term while baby's trying to latch. So again, areola here, and then you take your fingers and you just go around your nipple. I don't know what this is called, but just gentle, pressing into, like dabbling around the nipple to get what fluid has come right behind the nipple into that areola away for a few seconds, and then compress your breast and try to get baby to latch. You can also, in a pinch, hand express some of that milk, that initial milk, out to try to make it a little bit easier for baby to latch as well. Now, something we're not going to go full-fledged into today, it's definitely a topic for another episode. Oral restrictions or ties, you might hear it called tongue tie, lip tie, buccal ties, tethered oral tissue, all kinds of things. Those can impact the latch, and in doing so, make it more painful and less effective in terms of milk transfer. Now, just because baby has a tongue tie or a lip tie, it does not necessarily mean that they need a revision or that you can't comfortably breastfeed. Sometimes it has no impact. So it's just something to be mindful of. If a practitioner has mentioned, oh, baby has a tongue tie, oh, I see a lip tie, then it's something to be aware of and keep in the back of your mind. In the first few days, you're doing a lot of practicing for positioning with breastfeeding, and in doing so, you may notice improvement, and you should notice improvement in comfortability. If it feels like you're doing everything right, your positioning looks great from the outside, and you keep trying to get baby to latch more comfortably, but despite what you do, you continue to have pain or compression of the nipple or slow weight gain, that's when I would say let's definitely explore those oral restrictions as a possible contributing factor. Most commonly, lip ties don't negatively affect transfer per the research. However, what it can do is make it difficult for baby to flange the upper lip. My third son was this way. So he had a lip tie, and for the duration of the time that I breastfed him, I had to flip that upper lip into a flanged position once he was latched. So that could be as simple as just a small little adjustment on both sides. Make sure you do it on both sides. Or sometimes what you can do is get your thumb under the lip and just pull it up. And both of those things can help the upper lip flange into that good position for the latch and improve comfortability. So again, if you flange it out for them, then typically there are no significant impacts to breastfeeding with a lip tie. Now, there's a learning curve, right? There's a normal newborn learning curve. Trial and error is common, but I think the important thing there is to remember that your baby has never breastfed on anyone else. Your breasts are the only breast your baby knows, and so you guys are learning this together, and just keep at it and keep that in mind. It's normal. It's a learning curve. Practice, practice, practice. What can you actually do to fix a latch that isn't working? Start with nose to nipple to help your baby open wide. Aim the nipple toward the roof of the mouth. Let the chin lead in and keep the head slightly tilted back. You want the upper lip to come up and over the nipple into a deep asymmetric latch. Small adjustments in positioning can turn a painful latch into an effective one. When the latch is asymmetric, it creates a deeper attachment. Sometimes this is easier to achieve in different holds. For example, some people like the cross cradle hold, and eventually the cradle hold as baby gets bigger and easier to manage. Some people prefer the football hold or laid back breastfeeding. What I like about laid back breastfeeding is that gravity is an added factor here. So it's helping baby, even ungracefully, fall deeper onto the breast and really achieve that deep asymmetric latch that we're looking for. I always like to stress that laid back breastfeeding can absolutely feel ungraceful when you're first starting it, but please don't let that be a deterrent. It can be such a relief when you've been having feeding struggles that it's one of those positions that I would definitely say be persistent about trying a few times before you throw in the towel on it. Another thing you can do to protect your nipples is to break the suction gently before relatching baby. So sometimes we have pain and our immediate reaction is to pull baby away and to pull them away from our nipple. And what ends up happening is baby chomps down and holds on really hard, and then there's even more compression of the nipple happening. So breaking the suction before trying to relatch baby is really the way to go. And the way that you would do that is clean finger, go in the corner of baby's mouth, draw that corner up into a smile, kind of like that. I make all these great faces. Kind of draw up into a smile, or put your finger in between the gums so that if they chomp down, they're chomping down on your finger, not your nipple. And then pull baby away. If things have gotten to the point where you feel like you need nipple rest, first, I understand. Second, we can support you through that. One of the most important things that you can do is continue to protect your milk supply by pumping and removing that milk. And then when you give that milk to baby, try paced bottle feeding. It's a technique that makes sure that the flow of the feeding isn't so quick that it makes it difficult for baby to return to the breast. It preserves baby's breastfeeding skills. And because bottle feeding and breastfeeding are such different skills, and bottle feeding is an easier skill to learn, sometimes babies can develop that flow preference. And so with the paced bottle feeding technique, it protects breastfeeding and helps babies transition back to the breast. Even giving yourself one session as a break can a lot of times provide the healing and the rest that your nipples need to try again at the next feed. But also, if you need a full day, just try to remain in sync with baby's feeding schedule. And while baby's feeding, you're pumping and protecting your milk supply, and baby's taking a paced bottle. And when is it time to stop troubleshooting on your own and call for help? If you're still in pain after the first few seconds of feeding, if nipples are damaged, or if your baby isn't gaining weight well, that's the time to call for support. Because latch issues affect milk supply, comfort, and even your baby's growth if they go on too long. Persistent pain despite adjustments is not normal. If you can work with someone who can provide an extra set of eyes or give you some tips about how to adjust baby's position, your position, have them open wider, bring them in closer, etc., then you may find the relief that you're looking for to continue to protect your breastfeeding. When you have damaged nipples, bleeding, or recurring cracks, sometimes it can be difficult to think through a plan that both protects your milk supply and preserves your breastfeeding relationship while giving you the rest that you need to heal. It's okay to need to check in with someone and work through a short-term plan that gets you there so that you can return to breastfeeding if that's your preference. In the case of poor weight gain and not enough diapers, make sure that you're checking in with your clinician to see if there aren't any other issues going on, and definitely work with a lactation consultant who can help you maximize transferring for the feed and talk about ways to make sure baby's getting enough. Regarding suspected ties or structural issues, lactation consultants cannot diagnose them. They can certainly give you their opinion about what they're seeing, but you should work with a clinician who is able to provide clear diagnosis as to whether ties are an issue, and we can explore all kinds of opportunities for treatment or revision, etc. in another episode. It definitely deserves time to be discussed. Latch takes practice for both you and your baby. If it's feeling hard right now, you're not alone. It's a skill you both learn together. Sometimes it takes a few tries, and sometimes you need support along the way, and that's okay. You'll find little shifts that make your feeding journey smoother. If you're looking for show notes or resources, you can always find them at themilkproduction.com. And don't forget, I pull highlight clips from every episode and post them on Instagram, Facebook, and YouTube, all at The Milk Production. Thank you for spending this time with me today. I'll see you next week.
The Milk Production.